Briefly, I have put for you this chart. I will go quickly because they are simple, but it will also inspiring you about the treatment plan. For example, we have 3 stages. The first one is the diagnostic and planning phase, as Dr. Bassam talked about. He discussed about the communication and many of the planning skills. So I will not explain about it a lot of time. As usual, I'm confirming on the digital dental photography. I'm accounting it as one of the big facilities in your clinic. You have to provide it with yourself. How can I diagnose my case? Of course, by 2 points. Who can tell me about this rule? 80-20. Dr. Mohammed, بدلتها؟ 80-20. Who can tell me about that? Yes. دكتور قدر تجلبها بس. بينما 80% you should give the time for the patient. Let the patient to talk about himself, his history or her history. And 20% you give the time for yourself because the patient wants to express and you want to touch the patient's mind. This is the first one. After that, ask the patient, if you are dentist and a smile designer, what you are going to do it? Of course, we are not obey and submit everything that the patient asking us. We have a rules. We have a scientific rules. One is here and one is here. They are red lines. The patient, if they are playing within the rules, it's okay. But if they want to pass, for example, case indicated for ortho, they're asking us for veneers, we should refuse that. So let the patient to express what they want. Of course, all of you know about the DSD. It's really helpful for you to detect to many of the cases. This case, the yesterday case came to us before 1 week. She came, but yesterday just we planned it and mock-up returned it back for us. So we did a simple DSD after the picturing. And the picture, it was analyzing by DSD. So what I should do by this DSD? Either I have spaces to realign the spaces or to refill the spaces. I can do by 2 techniques. All of you know, is a mock-up. It means direct placement of the compost intraorally in the same visit chair side. It's wasting time, but it is quicker than the wax-up. Or you will have a DSD and you will send it for your patient to your laboratory, and the lab will make for you a wax-up. What I should do with the wax-up? Of course, the wax-up will guide me as I guide the laboratory to have a wax-up. I explain it, 0.5 mm, 2 mm thickness, and visualization, distalization, if it is possible. So the wax-up with the silicone key, I'm going to place, as we know, the temporally, the same thing for the crown and the bridge. And after that, I'm going to transfer the wax-up inside the patient's mouth by the aid of the silicone key. As you know, silicone key is the key of communication between me and dentist, then between me and the laboratory. How? By the DSD, I mean. Then it will come back to me and I will place inside the patient's mouth. The patient will manipulate. Sometime you can give the patient time, and don't let the patient to show to everyone. Why? Because sometimes the patient will show for the engineer, and he will think from the engineering point of view, oh, every teeth should be equal in size. And the mind of the patient are different. I want to touch the mind of my patient. I want to have the wish of my patient, not the others. So I will tell the patient, who is the very close friend, the best one? Your husband, your wife, your close friend? Just if they have information, let them talk about it. Otherwise, I will give you all information about the stylus colors. I will explain. Time is open. What do you want? I'm ready to help you. So, what we did is that compare between two videos. The first one is the pre-operative, and the patient was talking about her complaint, what she wants to improve. And the second one is the after mock-up. Why I did this mock-up? For the communication. But many points was important here. The case, the enamel of the case of the patient, her teeth was eroded. So I told the patient that I have to add 0.5 mm of your teeth because available enamel is important to be respected. So if you're going to compare between both of them by naked eye, it's clear there is a difference. This is in detail as an overview. So after this work, I'm going to let the patient go back home. Please and please and please don't allow everyone talking about your mock-up because it is not the let's say not the home. This is from the point. The other one is that when you are designing something for yourself, the others will have a lot of information. يكشتي زور بسيط كابرا قلت خاني تاوكر قلتي والله أري والله أو بشيء لبو خلشي بو تاوم كر أو لو خون بو تاوم نكديشتا قلت شو لو خلشي بتقول قلت كاشي مرمري دري أو لو خلكم بوم تاوكر دي أو لو خوش نزار تاوناكم. Yes, it is right. The beauty is from the eye of the beholder, but it does not mean that you have a sense. I want to be my smile to be like that, correlate to the clinical case. So then I have to go with the tooth preparation. Of course, I have a seminar about preparation tour, a very nice one. I'll do my best to explain more about seminar in the ICOS, and we'll do my preparation slowly. If you have a microscope, it's good like Dr. Khadr. Otherwise, you have to use a loop, 2.5x, 3x, and 4x. And all of them, they can help you because working in a minimum thickness, it will restrict you to work in the detail and to have a precise approach. Then I prepared my case. This is another case. If you see how I was doing, the first one, the previous one, this one, we have three kind preparation. Freehand preparation. It means someone, with all my respect, they don't know, they haven't, let's say they are not respecting humanity. They are going to redact tooth structure without guidelines. We have to fight them. This is my idea. The second one is that they are using some guide cutting burrs after the planning, like this case that I did. The best one, if it's possible, as my case here she asked me to have a most proclined tooth structure than her one. So I add the wax up here. It's spoke up right now because I transferred. And if you look of the angulation, I'm changing my hand. The angle of the burrs I'm changing because I want to be conservative. All of the technique is called additive technique. I'm working with the addition. I'm increasing some of the thickness, the volume, and finally I'm decreasing. You have to respect and you have to change the angulation. Some books say that two plane, some others say that 3 plane. As this case, it is according to the length of your teeth, the patient teeth, not your teeth. And after that, if you see here in this case, if you see here, I have enamel, non-touched enamel, and here also I have non-touched enamel. I put here the finishing line. I respected the occlusion canine guidance on the buccal surface. And also here, finishing lines a little bit after the roundation. Central is also a little bit finishing line detected. Otherwise, if you see the thickness, my technician for this case was Ahmed and Mohammed Osteruk Crystal. And the thickness one was about 0.3 and half, about that. So fortunately, we could finish our our case, and Dr. Omar, if you see, we respected the soft tissue precisely. It is paragingival finishing line. So after the preparation, we have to take an impression. It's important. I don't want to explain. And shade is better to have a two-step shade. One before the working because of the dehydration, and second one is after the preparation, before the impression. And provisional is important. Finally, with the lab, you have to finish it, and then you have to make a try-in and insertion. This is in general. Of course, the follow-up is important. This is in general if you are going to talk about the steps of the treatment plan.